Okay, so we are Kupenda in the United States and Kuhenza in Kenya. Kupenda means love in Swahili, and Kuhenza means love in a local dialect, Giriama. And the work that we do is focused on reducing harmful beliefs and practices about disability to improve children's lives. And I'm going to explain how we do that. But really, the heart of our work is stigma reduction. So the organization began in 1999 when Cynthia went to Kenya as a graduate student to study wildlife. She had no intention of starting an NGO, but while she was there, she kept driving to the wildlife sanctuary. And as she did, she would pass a special school. Now, Cynthia was born with a disability. She was born without her left hand. And so she noticed that at this special school, there really weren't many children attending at all. And she asked her field guide, why is that? Why are there no children there? And at the time, it cost about $15 a year to send a child to school, to a special school. And the field guide said, well, unfortunately, the families either won't send the children with disabilities to school because they don't think they're worth it, or they just don't have the money. So Cynthia went home and, she's thinking about these kids and she says, I'd like to really support some of them. And she starts talking about these children in the United States, and people in her community and her church actually say, well, I'd like to support some children as well. And within just a couple of years, they were supporting many children. She was sending all of this money to Kenya, and she realized, I really should start an NGO to formalize this, which she did. So in the beginning, the work was really focused on helping children access school and medical care. But then in 2009, something happened that really shifted the organization's mission. One of the teachers, Winnie Gona, at the special school, contracted HIV, and she went to her pastor and asked him for prayer and guidance. And he said, Winnie, you should stop taking your antiretroviral medicine to show your faith in God and start praying and fasting, and you will be healed. And she promptly did that, and then she passed away. And Cindy and Leonard, the Kuhenza founder, they were concerned. They said, okay, this really seems to be the root cause of a lot of the reasons these children are not able to access services, is because there are people like pastors, traditional healers, government leaders sharing misinformation about the causes and treatments for disability. And so they started to look at the prevalence rate. 83% of the population is Christian, 11% Muslim, but almost everybody sees a traditional healer. Traditional healers in Kenya see over 80 million appointments every year, just in Kenya. And so this has been the source of a lot of positive things for communities. Traditional healers do positive, practices and healing remedies, but it has also been the source of a lot of misinformation. And so they started to think about putting together trainings that would help these leaders understand the true causes and treatments for disabilities and shift their attitudes to a more accepting view of people with disabilities so that they could then have that influence in their communities. There's been, you probably are aware of this, but there's been quite a lot of research and interventions done to engage religious leaders. They've been influential in preventing and treating HIV, in reducing female genital mutilation, in improving gender-based violence outcomes. But there hasn't been a ton of work done to engage local leaders and religious leaders and traditional leaders around disability justice and care. So over the past 10 years, Kupenda and Kuhenza together have put together 5 different workshops tailored to these influential community groups, one of which are parents and caregivers of the children themselves, helping them not only to learn about disability, but then to become advocates for children with disabilities. The workshops are just a day long. We start with very participatory exercises that help people talk about their knowledge and attitudes about disability. There's then an opportunity for them to speak with people with disabilities. They as co-facilitators, or they come and give testimonies about their experience living with disabilities in their communities. And then we do have an action planning part where we say, now that you've learned a little bit about the medical causes of disabilities and the ways that the rights and laws in your community protect people with disabilities, how can you go and find these children and begin to advocate for them, both at the home level by identifying them, counseling them, and referring them to services, but also at the community level by educating people in your community about their rights and about their needs and about their value. We incentivize the leaders with different tools such as a certificate. Sometimes we've used shirts, we use badges. This helps them to be engaged with the organization, but what we've learned through a lot of interviews is that the incentives actually help them to be recognized as knowledge leaders in their community, because in most cases they are the first people in their community to have this type of knowledge. And so people began coming to them. They recognize them in leaders of disability information and treatment and services. We assess impact by looking at the knowledge and attitude changes that happen within the workshop itself. So we have a pre-post survey, and then we also have a weekly reporting form that helps us to follow up with the leaders after the trainings and say, what are you doing from your action plans? Are you encountering any challenges? Are there ways that we can support you in completing your action plans? And that's enabled us to see what they are actually doing in their communities. So on this slide, you can see we did a study several years ago that showed that pastors' attitudes were positively changing. About 75% of the pastors who participated in our workshop showed positive changes about their beliefs about disabilities, and traditional healers, about 50% of them. But in a later study, we saw that even more of them were taking action on behalf of the children. So we were funded in 2017 to 19 from the UK government, DFID, and they helped us to conduct a program evaluation. And what we found was on a whole, the trainees who went through our program, about 65% of them were actually going back to their communities and taking action to identify children, give advocacy talks, counseling and care, provide nutrition support. They were doing all of these things. So this means that on average, a single one-day workshop is sensitizing almost 5,000 people in a community and improving counseling and care and referrals for almost 400 children. And that's just in the first year. These leaders stay on and continue this work year after year. So we have documented this in a way that can be replicated by other organizations and enables us to have a consistent strategy to approaching these trainings. We have the recruitment guidelines. People often say to us, how do you get the traditional healers to come in the first place? And we have a whole system for how we engage the traditional healers and the different groups to actually get them to come to this workshop. We then have facilitators guides tailored to the groups. So the pastor's guide really focuses on disability in the scripture. The traditional healer guide looks more at the medical side. The government leaders looks more at the legal, the laws around disability in their community and internationally. And then we have the post guide that really says, after they leave the workshop, how can you help to support them and ensure that they are following up on their action plans? We have a number of other resources, such as a home visit and counseling guide, a disability handbook that has the 31 most common disabilities in low and middle income countries in very simple 2-page fact sheets that allow people to learn quickly about the disability and how they can support people with that specific disability in their community. They're highly pictorial and illustrative so that people with lower literacy can also learn about these disabilities. We also have a child case management app. This was originally developed in response to the pandemic so that we could do remote counseling, but we found it to be very valuable because it helps us to track progress using, I'm sure you're familiar with the Washington Group measurements, and then we've also taken the Child Status Index and tailored it for children with disabilities. So we can see what changes are happening in this increasing group of children who are being referred to our programs. The app also includes tailored counseling tools so that guide leaders who have never done professional counseling through how to counsel a child about therapy, how to counsel a child about education, how to counsel a child about stigma and their family. And then probably the most important feature of the app is that it prioritizes emergency care. So as we get more and more children, we now have hundreds of children in our database, but if any of them are experiencing malnutrition, abuse, illness, or medication noncompliance, it flags our staff so that they know they need to do an immediate follow-up to ensure that child gets emergency care. And our staff continue to tell us that this is a life-saving feature, especially during the pandemic, but it continues to be because children are in these children in particular have emergencies regularly that need to be addressed. This is our staff using the app to do family counseling. And this is a list of the organizations that are currently using our materials. We have an open source library of all of our tools, including the app and the guides that enable people to replicate these in their own programs. Or sometimes we do tailored support where we do a gap analysis, or we help them to design a tailored program for their own needs. And these are the 16 countries that these partners are working in. And I'm happy to answer more questions. And that's the link to our open source library. Hi, Shona. Hi, Jonica.
Hi, that's a great presentation. Thanks, Jessica. I'm really interested to know with the emergency care, what referral pathways do you use? How do you get the children what they need, or how do you refer them, or do you provide it yourselves?
Yeah, we are equipping the leaders to do those referrals themselves. So we have embedded into the app, we have both a paper-based version and an app-based version of our referral guide. And it includes the child protection centers in the community, the special schools, the assessment offices. It's a list divided by location so that they can make those referrals themselves. If there is a severe emergency, our staff will then help the leaders by calling the family immediately or visiting them immediately to support a quicker referral. But there is a list of services available.
And do you follow up once you've referred them to find out if they if they actually received help and whether it was successful? Do you measure that?
We do measure that, and that is one feature of the app that I think has really enhanced that particular part of our programming, because the staff would say, you know we just have hundreds of children. It's hard for us to keep track of who to follow up with. So there's some parts of the app will automatically prompt. So there's certain things that we say, check in with this family in 30 days, and the staff gets a prompt on their screen. I need to call this family to make sure that they've accessed a birth certificate for this child. Other things the app will ask the user, either the leader or the staff, when do you think this child needs follow-up next? And they can add the date, and the app prompts them in 3 days, in 7 days.
I'd also like to add that when we do our one-day workshop, we also give them a referral guide. So the people using the app have been part of that workshop, so should already be familiar with the different places to refer children in certain cases.
And just one last question. Once they have been referred and you've remembered and they've followed up, do you know whether the place you've sent them to has actually done the job? Do you have feedback from that?
Yeah, so every child in our database receives local leader counseling every 6 months. And if they are part of our sponsorship program, that means that they have a higher level of need. Then they also are counseled by our staff every year. So that's the type of questions that come up in those follow-up, those regular interval counseling, as opposed to directly connected to the referral. So we'll say after 6 months, hey, we see a record that you went to have this procedure done. The staff have told us that it was complete. How's everybody doing? Are there any side effects? Have you had any other issues arise in the last 6 months?
So hi everyone. Hi Jessica, I'm so sorry for being late to your presentation. I just jumped in 15 minutes late, sorry. But really amazing model and really great presentation. I think I definitely see the value in how it's been worked out and in how it uses local, existing roles, basically, with not coming from outside. I think the one question I had was, and sorry if I missed it, is it's been used in some other countries as well, right? And so, I mean, I think that the questions that Shona is asking are around what we experience here, in that you can refer a kid to a government service and they can pitch up, even we even sometimes end up making the appointment for them. They can show up on time and they will just be sent away. So yeah, I don't know if you had any experience with either other countries or in Kenya with that happening, and sort of, I mean, that's obviously an advocacy thing, and it's great to know that. So obviously you're capturing that, which is a really good start. But I think that's sort of our thing always, where we get quite,
Yep.
I don't
Yeah,
know,
I think
demotivated.
Cindy's going to have an answer to this as well, but I just want to share, I literally before this call got off a call with our field team, and they said exactly that, Donica. They were like, we are referring all these families to sign up for the National Council for People with Disabilities card. They go to the office and the office says, we don't have anyone to assess your child. The assessment officers aren't available today. So what the app enables us to do is see that trend. The staff is reporting that, but we're also regularly looking at the data, and we're saying, why aren't these families accessing the National Council for People with Disabilities? So in response, we as an organization can implement a program that says we're going to do like a mobile clinics type where we bring someone from the NCWP to this community that's underserved, and we're able to do services there based on the need that we're seeing come up in our data, because that does happen a lot. Yeah.
And I think that, as you probably know, Shanaquip, that it's both a bottom up and a top down approach at the same time. So at the same time that we're working with the community leaders, we're also working with the government leaders and some of the higher ups, and actually pointing out to them the legislation that they actually wrote and reminding them of what are their rights. And when Leonard, my co-founder, and I we're in Sierra Leone, when we're in Tanzania, any of the countries that we go to, we always make sure we have the country's Disability Act in hand, because most countries have it. And I have had the opportunity to literally talk to the people in charge of disability in Sierra Leone and say, here's your act. Like, it says that people go to jail if they don't include people with disabilities in their classrooms. Does this actually happen? And they're like, no. And I said, I'm not asking to judge. I'm asking so we can help from a community level to know how, because what the problem is the community isn't pushing from the bottom to get the funding for the legislation. So both things really need to happen at the same time. So we're doing both. And so like what Jessica said about organizing, one of the things we discovered is with the national health insurance, which Kenya has, which I know a lot of other African countries don't have, but at least it's a start. We learned that if our organization is registered with the national health insurance, we can actually get 3 kids for the price of 1 to be covered by insurance. And so if we do it through the organization, it's like about the equivalent of like $5 a month for 1 child, which is too much for many of our parents. But with our organization registered, we can get 3 kids for $5 a month, which is cheaper than us paying for medical services if we can get them registered. But that requires us bringing them all together. And so like Jessica said, when we have that data, like, okay, this is happening a lot. Calling them and counseling them individually is not enough in this case. We need to gather them. We also had some of our local leaders report that one leader, when I was just there at the end of November, beginning of December, he's like, I have 76 children I've identified with disabilities, and I cannot get them assessed to have a proper disability diagnosis. So our staff then went and gathered those kids, brought the assessment officer in, because we do have more pull that we can push them to come and do those things.
Yeah, no, I mean, that's really cool, you guys. That's really great.
Yeah. We just struggle. We also use the bottom up, top down, and middle pressure, but we struggle with the ability to follow up. I think we just don't have the capacity, and maybe the app is the key, the missing link for us.
Yeah, and I mean, it's capturing all of that, which is what you need to advocate, to go to someone with the act in hand and say, hey, what's happening? This is what's happening right now, and here's your act, and being able to show them that, because I think that's also where we're often obviously stuck, like many other places.
Well, in our Kenya specific, it's very Kenya specific, but it's a good idea for, I think, any country to develop, is actually a legislative guide, which we've gone through all the legislation in Kenya that refers to children with disabilities and made a very simple point thing. Like, by the way, if you abuse a kid, you go to jail. That's what these particular laws say, so that someone can simply understand what's happening. And so it's easier than bringing that entire law together. But sometimes that's all we have to go on when we're entering a new country. And I think the follow-up, just one of the things that I think is really important to understand is part of the apps, it was already in development, but in terms of this really intense follow-up, it started with COVID, really, that we really invested more in this because we realized that our team on the ground didn't have a really good follow-up system. They weren't like, they were randomly checking in on kids. It wasn't the same person each time. And I'm like, what's happening? I had like suggested, can we just have a spreadsheet? Because I'm like obsessed with spreadsheets, just like keep track of these kids. And then just like, maybe there's a better way, like the app, you know. And so this way they're really keeping tabs. So COVID actually helped us to realize, because we're like, when school is shut down, we're like, what is going to happen? Our kids aren't getting food. They're going to be left on, kids with cerebral palsy are going to be left on the ground and not moving around at all. What are some of the things we can do to just keep these kids surviving during the pandemic? And so we've realized that this is useful going forward too.
Yeah, I think that continuity of care piece is something I brush over it, but there's two modules, one that assigns the child to a staff member and one that assigns the child to a leader, so that that's their point person going every single time this child is counseled, it's counseled by the same person. So there's background information that staff can, maybe I haven't talked to that kid in a year, but there's a background page that reminds me, last time you counseled this kid, here's what you guys talked about. So that really helps for consistency.
Yeah. And that's on the app. Yeah, you see, we also launched the app, an app during COVID, but that was the monitoring of barriers in the community. So the parents could understand the policy, like you mentioned, like simplified policy, but then report on it. But I'm thinking that the actual continuity of care process would be really useful to investigate further for ourselves as well as an additional app.
Mm.
Yeah, and just sorry, Danica, go ahead.
No, go for it, Jessica.
Just in response, Shauna, I just wanted to say that we have a framework. We work with an organization called Damagi, who's developed this software. It's basically like app development for non-software engineers.
Okay.
And so the framework is something that any organization could tailor for their particular setting.
Yeah, I know Damagi very well. They're part of Schwab, and yeah. So how many children are on this app now?
We have about 700 in our database.
Okay.
Yeah, which is a sample. That's just a sample of the children we reach, but those are who we're tracking more closely, mostly in relation to need.
Okay. All right. No, then that makes sense.
I feel like it's Shona Quip coming with all the questions, but while we're doing it anyway, like everyone excuse me.
Unapologetically.
I mean, we're like, sorry, but anyway, gonna ask, any luck on like government departments willing to take up using the app? Because I mean, I can just imagine our Department of Social Development using this because they have no process, no follow-up, no database. Like any luck with anything like that?
We're currently talking to Catholic Relief Services. They have a new group called Changing the Way We Care. Maybe you guys have heard of them. And
we work with them on that in Moldova.
You do? Okay, great. Yeah. So they're a coalition, I think. Who are, Genevieve, remind me, who are the partners there?
Changing the Way We Care is CRS, Maestral, and it was Lumos, but it's now really just a Maestral and CRS initiative.
Okay, thank you. And they are working with the Ministry of Health and I think the Ministry of Social Welfare in Kenya, and they are familiar with our tools and have come to us and said, we would like to start using your tools in this work, mostly around family reunification. And they're specifically looking at the app and some of our training tools. However, their headquarters are making them go through a procurement process. So they're saying, we know that we want to work with Kupenda, but we have to go through a procurement process. So that's their funding ends, I think, in the next year for that. So we're hoping to start working with them, pretty soon.
Okay, I have about 82 questions, but let me try to formulate just one or two specific ones. First, I want to just commend you. I mean, it's really excellent helping the communities to be able to make data-driven decisions. The way that you're tying through and advocating and educating about the legislation that already exists and trying to help the government be responsible for their own citizens as you're providing support to that effort. It's just beautiful. Like I love every way you're thinking about all of this and making it come together, and that you're open sourcing this and allowing others to help. One of the pieces that I'm most interested in is the success of the app that you have been able to pull information into, because in the Republic of Moldova, we're struggling a bit with some of the similar things, that everyone really just knows each other. We've been operating in Moldova for 20 years. We're a 50 years old organization, but in Moldova for 2 decades. And everyone our whole team is Moldovan nationals, and the whole country is only 2.5 million people, right? And so the way that all of the work has been getting done in deinstitutionalization and community building and identifying needs has been easy to manage on spreadsheets, to your point. But now it's starting to get a little bit unwieldy, and especially with the pressures of the influx of refugee families, and trying to map and identify where families with disabilities are in this pretty organic response. And so thinking about that, but also wanting you to speak to the pressures of safety and security of the information that you're keeping in the app. So that's one of the things that's coming at us a little bit hard on the responses of the data collection right now, especially in the context of cyber attacks and safety of children and families. So how are you managing that?
Yeah, so Kenya has a data protection policy that we've developed, basically a corresponding user agreement. So before anyone downloads the app or accesses the material, they sign an agreement saying that they understand that they need to protect this data. And anytime that we export it from the platform, the ComCare platform is where we export all of our reports, we're able to hide the children's name because every child is assigned a case ID. So that really enables us to protect. We have a organization doing a analysis for us right now, and they're only using case IDs. And I can answer more questions about that if you have more, Genevieve. But in terms of mapping, just to mention that there is a GPS feature, a GIS tracking feature in the app, where we've been doing a lot of remote counseling because of the pandemic. But when we do start more and more family-based counseling, when you're sitting at the family's home, you press a button and it collects the GIS coordinates, which is going to allow us to map where all the children are, where all the leaders are, where all the services are, so that we can then use that to inform programming and advocacy.
That's super.
Jessica, could you talk a little bit more about your experience with the open tools that you've put out? I was so impressed with the list of people who are using them, and also like the fact that you know that. I think that's something that we are trying to think about at Spoon as we put out tools. How do we know what's happening with them? So I would love to hear a little bit more about that, and also like whether you've done any work within these organizations to kind of create demand for the type of tools that you use, or was that demand already there? And is this something that people have mostly come to you for?
Yeah, I'm going to say a couple things, and then I know Cindy's going to have a lot to say about this too. So we do a training. We don't have a separate facilitators guide because it's so all-encompassing, but we do a training specifically for NGOs, so around disability justice and care. And so they can start to think about ways to make their programs more inclusive. We've presented about this work at conferences around the world. We're part of, I think, 11 technical working groups now. So we're sharing this very broadly. We also follow something, and I think you guys probably know it, but ICT4D principles. Okay, so that really focuses information and communication technology for development principles, guide our work in ensuring that it's human-centered design, but also available for the community at large. And so whenever we talk about our data, whenever we talk about our tools, we're saying this is available for use and we want it to be used broadly. So that's helped a lot of people to get an interest, at least start looking at the tools and thinking about ways that they can adapt them for their use. And I know, Cindy, I'm going to pass it to you because you have a lot more experience with this part.
Well, I would say people don't always know what they need in terms of disability inclusion. And so we're often in the business of helping people to see their need with disability inclusion. So part of, like, we just did a webinar a couple weeks ago with an organization that had like World Vision and Cure International and so on, where we actually talked about disability stigma, because our real niche as Kupenda is to address stigma directly. So many organizations dealing with disability seem to be more clinical, and that is a need for sure. But we're like, we don't need to be one more organization dealing with the clinical side. We can be someone to connect them to those dealing with the clinical side of disability. But we really want to be more a part of the destigmatization and the human rights challenges that are connected to disability. And so we've learned one of our big roles is working with other organizations that are international development organizations that don't necessarily have a disability component at all, where we've actually written several like just 2-pager informational papers on, say, gender and disability and how Kupenda is resolving that, basic and orphans and disability and climate change and disability and WASH and disability and public health and sexual reproductive health and disability, because we want people to understand, as you know, I'm sure, how disability is intersectional. Like, if you care about women, you need to care about disability, because women are twice as likely to have a disability, and just even for us, doing these fact sheets helps us to develop talking points when we're talking to these organizations. We have literally had a fairly large organization, which I won't mention their name, after we went through talking about disability challenges, the person followed up and said, well, how are you helping vulnerable children? We're like, how do you not see that people with disabilities are obviously vulnerable children? Because I think that disability, even in international development communities, seems to be pushed off to the wayside. It's just not thought about. And part of the reason, I think, is people don't see people with disabilities because they're hidden. I have literally had some friends go on a trip to a church in Haiti. And I asked them, like, so did you, they said they asked the person because of their experience with us, the pastor, do you have any people with disabilities in your church? And he said, no. I'm like, well, obviously that's not true. But one of the reasons they would say no is because it's seen as a shameful thing, because obviously you're not doing your work as a pastor if you're a pastor that considers healing to be a success. If you have children with disabilities, for example. So I think we're in a big business of creating the demand and helping people to understand. And as I think that organizations like USAID and other funding agencies are requiring disability inclusivity, a lot of people are starting to come to us a little bit more, and there are more forums for us to actually have a voice. But I will say, I think that one of our biggest things is to help people understand, when you're talking about vulnerable children, you can't talk about vulnerable children without talking about disability. And you can't talk about disability in low-income countries, especially, without talking about the superstitious beliefs, which are prevalent in every low-income country I've dealt with. And unfortunately, it is also in the United States too. I have had a personal experience. My niece died a year ago from cancer, and a faith healer showed up at my brother's house in Newburyport, Massachusetts, telling my brother it was unresolved sin that was causing her cancer. So it happens in the US, it's just a little more hidden. It's not as out there. So I think it's an important issue that people usually don't understand is happening until they've experienced it themselves.
Yeah, if I may, your programs really echo with what I observed in the field, especially in West Africa. And as you said, you can't talk about vulnerable children without talking about children with disabilities, but it's the same with you can't talk about family preservation, family reunification, family-based care without addressing stigma reduction. And we do address those kind of topics, but never in the way you do. So I'm so happy that you have this open source materials. And I was wondering if you provide technical assistance to use them concretely.
Yeah, and Jessica, I think, can send our capabilities statement that shows the different ways, but we have in multiple countries we've actually done a few trainings virtually in the pandemic. We were able to do a training in Burundi and Malawi, and also in Rwanda, where it was with multiple African countries represented through other organizations. But we did basically an NGO training for those organizations to talk about the belief systems, because I realized when we did a pilot project in Malawi with World Relief, that working with the local community, having them be the ones that are in charge at the country level is really important. But one of the things that people didn't realize is many of these cultural stigmas existed in their staff at very high levels. And so it's important to say, before you can even start to talk about the community leaders, like, what do the NGO staff believe about these things, especially when you're working with, well, no, I think it doesn't matter whether it's a faith-based or non-faith-based organization, to find out, like, at the staff level, because most people in most countries we're working with are going to have some kind of religious affiliation. So they're most likely going to have a lot of these community beliefs. And so I think a lot of people aren't asking the questions. And so we have an NGO training as well. So we're talking to the organizations first to find out where they're at. We also have done actual trainings on the ground in at the request of the organization. So in Sierra Leone and Tanzania, in Zambia, we've come and done the training ourselves. Either myself or one of our staff member from Kenya has gone and done the training. So we're offering that. We also have done gap analysis for other organizations in terms of their training tools to do community outreach. This was a non-disability focused organization, but to say how is some of what they're teaching in their outreach efforts actually mistakenly excluding people with disabilities. So those are just a little bit of a taste. Jessica could add to that.
Yeah, I'm just going to put a link here that kind of summarizes our experience, the different types of ways that we provide TA to other organizations.
And we believe really strongly that there's so many organizations on the ground all over the world that we believe the most effective way, or I believe the most effective way that we can reach more people with disabilities, which is over 1.2 billion people, right? The most is to work with the organizations already on the ground, as opposed to us trying to replicate ourselves all over the world. We want to come alongside and help other organizations that already know their communities, just to be more inclusive.
It's really interesting, this conversation, because we're busy now just starting at last to roll out Disability Stoplight, which is part of the Poverty Stoplight package. And one of the places that it was trialed is a well-known leading disability organization in South Africa. And we've realized that it doesn't matter where we do these trainings, we are going to have to do disability sensitization and anti-bias dialogues first, because many of the old established NGOs in the disability sector are actually part of the problem, seriously part of the problem. And trying to explain that to our partners who are working in Poverty Stoplight has been quite a revelation to them, because they just took for granted that any organization with disability as a focus would know what they're talking about. But the dissonance within the sector is actually shocking. We've always known it's there, but now it's being highlighted because the conversations have to bring to the surface the deep realization of the bias that people in these organizations hold themselves. And actually, it's what drives these organizations and has driven them for 20, 30, 40 years. And then you see, okay, this is where significant work's going to have to happen, because people use those organizations as almost like a lighthouse that guides their decision-making. And that's where it just constantly goes wrong. It's spinning out.
Yeah, and I think it's really also the medical model and charitable model of disability. It's a step from some of the traditional beliefs and superstitions, but even in international development communities, we still focus on the like fixing people with disability, which is part of inclusion in some cases. But it's so often like some even of the stories that people with disabilities on the ground will share in DPOs is, oh, I had this problem. Now I don't have the problem anymore. And now I'm married and I have children and I have a job. And it's always like this nice, beautifully packaged like success story. But that's not always the story for a lot of people. Like, I don't think that having a job and getting married and being independent is the measure of success for every person with a disability.
No,
And so we have to be really
exactly.
careful. But that is often the story I hear from DPOs, which are often people with physical or sensory disabilities, I've noticed. So the DPOs are strongly biased towards those without including people with behavior, neurodiverse, that kind of, and intellectual challenges.
Yeah.
That's one of the questions I wanted to ask is how are you finding, you know, through the use of Washington group questions and I forget what was the other one, the measure evaluation tool, I think the
Child status index.
Okay. As far as being able to identify children with intellectual disability or autism, is that a struggle still, or is that?
Well, we've done specific trainings around autism. We've attempted to educate some of our leaders and some of our teachers around the signs of autism so that they can support diagnosis. Again, it's often dependent upon where we're referring them for assessment, whether or not they get that diagnosis. But we are starting to track it. I imagine that over time, we're going to see the rates of autism and other intellectual disabilities increase, not because there's more children, but because we're able to track it better. So I think we're at the beginning of that.
That's been one of our struggles in just trying to find the right short set of questions that actually gets beyond some of the.
Yeah, I was going to say the Washington group measurements, they're helpful for organizations at large to just like get some sampling of disability data because there's so little data at all. Like they just want to get something that, but to really like our community leaders currently are not in the business of diagnosing. They are only doing referrals for diagnosis, which we hope will be accurate. So they're not, but our director in Kenya is actually part of an organization, an initiative called Spark, where they actually want to work with community leaders to train them on both on mental and intellectual challenges so that the community leaders actually could be trained to do more of that assessment because there's just not enough assessors, there's not enough people, and they've asked our director to be involved because of our success with community leaders. COVID stalled it a little bit, but they're back in action again to try to do this initiative. And this is with the government and Aga Khan Foundation on that hospital.
That's so great. I mean, because as you well know, that especially when we're talking about institutionalization, the kids and adults who are getting left behind, even in those stronger approaches, are still people with developmental disability often, or most kind of complex support needs. And, you know, still hearing some of the pushback of like, well, maybe congregate care settings are appropriate for certain situations, certain people, and that, you know, pushback and is, as you rightly mentioned, thinking about educating those who are supporting communities and families to assess and diagnose and understand that there is also options for them and the support that they needed, they deserve, and they have a right to receive. So.
And as Shauna has, we also have a parent support group model where we get families into parent support groups, and those support groups, actually, I would say this is one of the major benefits for a person with a disability living in a low-income country versus in the United States, for example, is their community structure is already set to help one another. They are, you know, they breastfeed each other's kids, for goodness sake. Whereas once the stigma is gone, we have seen those families supporting one another at the community level. Single moms, which is so many of our parents, are being supported by other community members. Once they understand that this is not a curse, that kid is included, and those kids with more support needs are being supported more by the community. And I've found that I have been asked to do trainings here in the US. I'm like, this is what we can learn from them. It's really challenging. I've met people with disabilities or families affected by disability in the US. They're so alone, and it's so individualized that they suffer from not having that community support, which I think is one of the biggest benefits we have in the countries we've been working in. Once they change the stigma, they've got a community support system. We have to create it in countries like the US.
100%. Excellent. Completely agree. Yep. Excellent point.
So some of our team at Spoon has a call on this channel in 3 minutes. So maybe just to ask Jessica or Cynthia if there's anything else that we didn't ask you about that you wanted to make sure that you got across before we close.
Yeah, I don't think so. I did put the chat in the chat our the links to our open source tools and our summary of our technical services. But if anybody just wants to talk, to us in about ways that we can collaborate or think about programming together, we're happy to do that in a separate meeting.
And is anyone going to be at the IDDC in Belgium? No one. Okay. I was going to say I'll see you there maybe. I haven't bought my ticket yet, but I'll see someone. All right. Thank you so much, everybody. I really appreciate it. If you've come up with questions later, feel free to ask.
Yeah.
Thanks so much. It was great.
Thank you. It was
Ta-ta.
really
Thank
great.
you so
Thank
much.
you.
Bye, everyone.
And Marie and Genevieve, we have a different link for our next meeting. It's
Different thing here.
yeah, it's in the invitation. So
All right, we'll
stay on
pop
here.
over there.
Okay, see you in a couple minutes.
I have another
Bye.
call, so can't join.